Welcome to the Fan Method, the aesthetics, health, and wellness podcast dedicated to helping you look and feel your best inside and out. Stay tuned as we explore what stem cells are, the latest innovations on how they're being used in plastic surgery and aesthetics, and the practical considerations you need to know if you're thinking about incorporating stem cell treatments into your own personal health and rejuvenation. Whether you're curious about the science or considering a procedure yourself, this episode promises to arm you with the knowledge you need to know to make informed decisions and to separate the hype from the reality. Before we dive in, I want to remind our listeners that today's discussion is for informational purposes only and should not be considered medical advice. As with any medical treatment, it's crucial to consult with a qualified healthcare provider to determine if stem cell therapy is right for you. So let's jump in and discover the truth about stem cells. I'm your host, Dr. Larry Fan. Our guest today is Dr. Michael Longaker. Dr. Longaker is a pediatric craniofacial surgeon, research scientist, and co-director of the Stanford Institute for Stem Cell Biology and Regenerative Medicine. He has dedicated years of research to tissue repair, tissue replacement, and tissue regeneration harnessing stem cells, leading to more than 1,200 peer-reviewed publications. Dr. Longaker is truly a global leader and role model for those physicians and scientists who aspire to improve patient care through regenerative medicine. Dr. Longaker, thank you so much for joining us today.
Thank you for having me, Dr. Fan.
I'd love to learn a little bit more about your background and how you came to be one of the leading researchers in stem cells and regenerative medicine.
Well, that's an interesting question. I'm an accidental everything. So I was born and raised in Detroit area, Detroit, Michigan, on 13 Mile Road. If that's meaningful, 8 Mile, the movie of Eminem. So I'm in the town of Warren, which begins at 8 Mile. 0 to 8 is Detroit, and then Warren, 8 to 14. I'm on 13 Mile. My father was a professional baseball player. My mother was a housewife. Lived in a 900 square foot home, 10 feet from our neighbors. It was a fantastic place to grow up. It's the only thing I knew. And I think two things really I was blessed with as I look back. I could always run and jump. So I was a heavily recruited athlete in football, basketball, track, and I had a good memory. And somehow I've leveraged those two things into my career. My dad decided in those days there's no ESPN. So he decided I should go to Michigan State for basketball, which I thought, okay. So I would go to Michigan State, could never have predicted Magic Johnson would come. We'd win a national championship in the most watched game of all time. Not even remotely would expect that. And I wasn't a star. I was a star in high school, but there's a pecking order in the world, and he's going to be one of the top 5 players of all time. So it was a fantastic experience. I then went to Harvard for medical school after that, thinking I was a computer error. Well, no computer, whatever. I was a clerical error. But I get into Harvard Medical School. I didn't do any research. In fact, I played basketball in the summers with Irvin and my teammates while my classmates were doing research. So I always heard about UCSF. I wanted to match there in general surgery. So I matched there in general surgery. Halfway through my 5 years, we get a new chair of surgery. And this is a true story. He's looking through my file, half glasses, posh British accent from Eritrea, Haile Debas. And he says, wow, you're a really good student, but you've never done any research. And I blurt out, Dr. Fan, without even thinking, Dr. Debas, I don't want to do any research. So he just looks at me and he says, a frontal release is something that's usually before age 2. A 2-year-old will think it and say it. Or like after 90 at Thanksgiving dinner with Grandpa. He said, you are how old? I said, 29. He said, well, wow, okay, so that's amazing. He said, now I'm going to ask you to name your name tag. So I did, resident 3 in surgery 6. Did you read mine? I thought, oh boy. He said, so we're level set here? I said, yes. He said, so this is an important question now, Michael. How would you like to do a year in the lab? I said, I'd love to. If he writes down trainable ? So I'm like, oh my gosh, what did I just do? So in those days, you start in July 1st, as you know. So sometime in early June, I get a note, a typed letter from the admin saying, you're going to be starting in the pediatric surgery lab with Michael Harrison. I said, great. Now, your audience wouldn't know this, but in 1981, Dr. Harrison was the first person to operate on the unborn patient, to open up the abdomen, open up the uterus, operate on the fetus, because it'd be too late to wait. Heroic surgery. So I'm joining lab in 87. So he had probably done 7 or 8 cases. Anyway, I screw around for 3 months, moonlighting. He asked me at a group meeting how the moonlighting is going. And rather than saying, I don't know, I said, I love it. I'm making a lot of money. And he's like, oh my gosh. Okay. So he said, well, why don't you look at the way you heal before you're born? So guess what I blurred out? I don't think that's a big medical problem since you're the only one in the world making, wounds on embryos. So he ended up, I was operating on a fetal lamb the next week, and lambs are born at about 150 days, long gestation. So I operate on a 70-day lamb, and I make these 2 big wounds, excisional wounds, close the uterus, come back 3 weeks later, and open it up, perfectly normal. So my first thought is they were twins. My first thought is, oh my gosh, I've opened up a twin I didn't operate on. And the other fellow said, no, this was the stapler line. So I'm excited. I take pictures. We get that we have to develop Kodachromes at Artefam. This is 1987. So I put it in the projector, super excited. My wife's excited. And he says, what? I said, you're right. There's no scar. He said, but how do I know there was a wound there? I was so mad. I was like, oh my gosh. So I had to do another operation the next day, and I put marking sutures around, but I went from euphoria to these people don't believe me. So anyway, that's a long-winded explanation to say I was forced in the lab. I was assigned a project by the one person in the world who could think it. And for 37 years, I'm still working on that. So I then thought, he said, you should be a pediatric plastic surgeon. It's called craniofacial surgery. I had no idea what that was because it's not like in general surgery, UCSF, we did a lot of time on plastic surgery, no time. Yeah. So I ended up doing 9 years of general surgery instead of 5. So my 1 year in the lab became 4, changed my whole life. I was obsessed with scarring and why 8 billion of us outside the uterus heal with a scar and the tens of millions of embryos inside the mother's womb heal without a scar. Yeah. And when does that change? It's latent gestation. So that was my career. I then went on to do plastic surgery for 2 years and then a year of craniofacial surgery and went back to NYU where I was and had a lab. And it was an interesting time because I had to build labs from scratch. It wasn't like UCSF, which was blessed with these incredible labs in surgery. So it all worked out and I moved out to Stanford in the Stanford-UCSF merger 24 years ago. And I would say that the discoveries that I'm known for were either someone asked me to do something, like Dr. Harrison, who's still my mentor, or training with very talented people at Stanford in medical school, residents, et cetera, who made discoveries. So I think I've been blessed to be on great teams. Just as Magic Johnson was a fantastic player and I was okay. Yeah. That was a little humbling because in high school I wasn't okay, right? You go from big fish to minnow. Yeah. But it all worked out. So I think I'm a kid from the Detroit area who somehow has become a scientist. I'll leave it at that.
Wow, that's fascinating. That's such an amazing journey. And when I hear it, it sounds a little bit of like the way life works. There often can be a lot of serendipity involved, and at the same time, there's some threads I can already sort of hear through your life. I'm curious. I wanted to ask you, how did you go from someone who had never done any research and even, it sounds like didn't particularly have a lot of interest when the topic was brought up, going from that to being an extremely passionate, dedicated, capable sort of researcher. And, and I can share with all of our audience, as someone who also trained at UCSF, well behind you, but I remember sitting in the lab when I was doing research and reading some of the studies.
Sorry you had to do that.
No, to me it was actually fascinating, and it really showed the potential of sort of regenerative medicine. But how did you go from sort of, hey, research was kind of a foreign concept to, oh my gosh, this is something I'm so dedicated to?
Well, it wasn't planned. So I'm forced in the lab. In fact, Dr. Harrison, I had finished on a congenital heart surgery service, and I was asleep in front of his office on July 1st because I'd finished at 5:30 a.m. So he told me to go home, take a shower, and take a week off. And for me, that was a panic attack. I'd never had like a week off to do nothing. So I get my yellow pad, my briefcase. I don't know what to do. I'm ready to go the next day. But So I didn't know what to do. So it was a panic attack until he gave me an assignment. So I'm not a fumbler, but remember, it's not my idea. Now, he does not like that because I've received a lot of major awards when I've asked him to attend, and he thinks it trivializes my role. But I said, it's true. I didn't fumble it. So it happened on the margin every day. But the reality was every abstract I wrote, it was accepted. Every manuscript. It was just like people were starved for, what are you talking about? Healing without a scar. So I would say I go from an R3 where you're doing cases and feel like you're doing things, but you're not at the level of a senior professor, to having an international reputation by the time I'm a second year in the lab. So I decided to do a second year, which everyone thought was crazy because I was forced in the lab. So now in my fourth year, I now have a very large team, the equivalent of like the chief resident. We had written 2 NIH grants. We had published, over several hundred papers, which is absurd. And it was fantastic because I felt like, okay, I'm really leading this field. And when I go back to trauma and I'm doing my first gunshot wound to the liver, I won't be leading. I mean, it'll be different. So it was a very, I guess, a dramatic positive reinforcement with every presentation. And I was being asked to do all these things around the world, not as a professor. I would have to say, I think you want Dr. Harrison. No, we want you. And I'd be like, okay, I'm a postdoc. So everyone was always disappointed when I got off the plane because it wasn't some senior professor. But so I thought, okay, we're just going to keep going. And then the same person that forced me in the lab said, okay, now you did 3 years of clinical. It's your 4th year in the lab. I think you're overdoing it. I'm like, okay, what? So he said, oh, finish now, and I'll get your PhD, and we'll bring on the faculty. Or if you finish surgery, then you'll have more options. So I thought, okay, I'll finish general surgery. So it was like a little bit every day, Larry. But it just, at some point I realized, okay, this is incredibly fascinating because we're writing this trajectory. And I went from reluctant and panicked to still not totally comfortable, but, we're doing papers. I wrote textbooks. It was absolutely insane. And I can't think of any other place that would provide that fertile of a soil to take someone with no background who is a hard worker. And I hope I can give my research fellows handoffs like that, because Dr. Harrison's still alive. He's an amazing person. And now there are 500 or 600 fetal treatment centers around the world. So you imagine that impact. And I'm one of 400 or 500 people he trained. So for me, I'm very grateful to UCSF to give me that opportunity. I could never have predicted it in my whole life. And then it just, over time, you get better at it. So, I'm asked the question, how did you discover the skeletal stem cell? So for your audience, they may not know that you have a single cell that gives rise to hard bone, spongy bone, and cartilage. And it's called the skeletal stem cell. So that was a grad student who became a postdoc, and I still remember the day. I saw it. It was in a confetti mouse, rainbow colors, and there it was. And I thought, oh my gosh, there's a moment that you look back. So that was a big deal. And then 3 years later, we just identified it in humans. So now I sit here and I think, for the audience listening to this, they're thinking, okay, so this guy went from basketball to this, to that, to that. So to say, where's the puck going if you're a patient? So there are 78 million Americans today who have arthritis, and that's going up in an aging population. So we do anti-inflammatory drugs. If you have, it's really advanced, you have the incredible ability to have a hip replacement and your pain is gone right away. I don't know what people did 80 years ago, Dr. Fan, but they probably drank or whatever, wheelchairs. But now we have an ability to do that. The question is, we also do 4 million times a year you're looking in a joint. We don't look in the heart with a telescope or the liver, but orthopedic surgeons have arthroscopy. It's millions of times. So then I thought, okay, what can we do with this? So I thought, well, in mice, where all experiments start, let's develop arthritis by doing by taking away the ligaments. Think of the ACL going out. They walk funny and they have arthritis. And then I said, what could we do a microfracture surgery? So microfracture surgery is you have a hole in your cartilage. It's sore. It's painful. The orthopedic surgeon drills a hole through it so that the bone marrow cells come up. And that's done probably 500,000 times a year. But it's a fibro cartilage, a scar cartilage. It doesn't last. So I said, well, if we use these two things, which are FDA approved, could we regenerate cartilage? And that would be a big deal. So we're able to do that. And that was published 2 years ago. And now we're just starting large animal models. There's an example where fundamental discovery is coming along. It's not fast enough because you want it yesterday.
Yeah.
But if you're a surgeon scientist, you want to make a discovery that helps patients in your office or anyone's office. So I think discovering something is great because there's no translating without discovery. So there's an example, the skeletal stem cell. If it works in pigs, could we do this to get lesions that are not large enough to have a joint replacement? To regenerate, I think we can. Yeah. We still have work to do, but that's an example of what a patient on this podcast could think of. Similarly, you have thousands of people listening on your podcasts, and you start with the concept of you can get a wound to heal without a scar in utero. So we talked about getting a wound to heal without a scar. Yep. A plastic surgeon would love that because instead of remote incisions to hide it, you can work wherever you want. So the question is, how's that going to work out? So we made the discovery that you could heal without a true regeneration. Now, think about it. Scars are a little different than normal skin.
Yeah.
On the scalp, they don't have hair. They're bare. They don't have sebaceous glands. They don't look like the skin around it. And they're only 80% as strong as skin, despite all that collagen. Most people think the scar is stronger. So you had to show all those things were met. So now we did it in red Duroc pigs. Your patients on this podcast or the listeners don't realize the most human-like skin of all animals are pigs. Humans, your patients have special situations. We underheal with ulcers. We overheal with hypertrophic scars and keloids. So humans are very unique. So the pig skin is the most like it. So now, somewhat confidentially, we just submitted the paper. It works in large animal models. So on Monday, we sent in the first pre-IND called Interact with the FDA to say, we would like a human clinical trial using the drug that got mice to heal without a scar. And that's like a huge deal. Yeah. 1987 to now is 37 years. So for your audience, I guess I'm a slow learner, but I'm persistent. So here we are standing at the threshold. Yeah. So being a pediatric plastic surgeon, because you've done these operations, if a child is born with a cleft lip or palate, it's a significant thing in their life and its form and function. So between age of 12 and 18, we're going to have 15 people. It's routine to get a scar revision, 3 different doses at Packard Children's Hospital if we get approval to go forward.
Yeah.
So for the audience, you say, how do you do that? Well, we were really lucky. And I think it's really wonderful to be lucky because the drug that prevented scarring in mice is a blocker of the last gene, the transcription factor that gets activated when a fibroblast senses strain, the cell that's going to make the collagen. Yeah. This drug was FDA approved 24 years ago for macular degeneration. So you inject it in the eye, IV, and then it has a special ingredient that activates it in the light in the eye to block blood vessels. That has nothing to do with what we're doing. Yeah. But it means tens of thousands of Americans have had it IV. Yeah. And we're talking about a one-time local injection like you do Marcaine on the way out. Yeah. So that is exciting for me. The FDA may ask for a few other things, but for 24 years, Americans have been using this IV. And that dose is 150 times the local injection. So I always ask, do surgeons do injections on the way out? Yes, patients don't realize we inject lots of things like long-acting anesthetic, whatever. Yeah. It doesn't add any time in the operation. And the toxicity of this drug is very well known because it's been given IV. So, call me crazy, but I hope that we'll get approval to start a first in human. Now, a lot of patients listening to this don't realize how drugs can be approved, right? So this is an orphan indication. There's less than 200,000 people a year who are afflicted with cleft lip and palate. It's actually 7,000. But orphan means under 200,000. So, for example, Botox. Patients listening to this may be getting Botox, paralyzing their muscles. That was approved for facial tics after Bell's palsy, where you just, for the patients listening, you may not know, but involuntary muscle spasms after being temporarily paralyzed. So the off-label use over time has gone not to that. So I'm not naive. I realize there are 50 to 80 million incisions a year. Only 7,000 are in clefts. I want to start with that because that's important to me. But I want to get it approved in an orphan indication. It only requires 2 trials, not 3. But it's a smaller market, but it's important to me.
Yeah.
But do I believe in my heart 5 years from now that patients will be able to get their incisions to heal without a scar? Yes, I do. And that's wonderful if you're a patient out there, because I'm always asked, Dr. Fan, are scars important? And I say, only if you have one, and only if you have one on your face and you're 4 years old. If we don't get that child looking as normal as we can before kindergarten, guess what? Frontal release, someone asks, what's wrong with your face, right? So you make these fundamental discoveries and your patients and audience are wondering, okay, when's it going to hit? So I can say, if we do the first in man in 2025, I'm hoping by 2028, we would have the ability to use this in surgery. Now, lots of reasons it won't work, but I think the preclinical data on mice and pigs would suggest it will. And we know that tension is not your friend. You know that instinctively. So yes, there's a lot of work to do, but I'm just thinking it's been 37 years and I'm either going to do this or die trying, because it's, you work on something for so long, and I get probably 1,000 emails a month. There are people who buy Visudyne, ask the surgeon to, it's not how, we'll get into that. So what happens? Our patients are desperate to use something, but we haven't done the trial yet. So yes, you can buy this drug for the eye, for eye, but it gets activated by light, so there can be some staining. There's lots of reasons. And I'll simply say to the audience, I'm more anxious than they are to have this done, because it's been my life since 1987. And I get it. There are people who are listening to this podcast who say, stem cells, I mean, we're 50 years into a war on cancer with Richard Nixon, or 60 years. Stem cells have been around embryonic since 2000 and 1998. Why hasn't it impacted? It takes a long time. But I'm here to say, at least in the areas of arthritis, with 78 million Americans, 80 million incisions, there are spectacular things coming that are not pie in the sky. I would not want to be the FDA commissioner, because at the end of the day, you're signing and you've done 1,000 patients or 2,000. But what if the complications need 1 million patients? Right? How many? I think about it every day. Insulin is the most safe drug in the world, right? How many millions of Americans are on lipid-lowering drugs? Well, what if it takes 100 million lives before we see a complication? So you never really know. But you have to say, have we done everything to be safe? So it prolongs it, but at the end of the day, the United States FDA, you must be safe and efficacious. And in Europe, also a very first world situation, only safe. So the bar here is the highest. I'm frustrated by it. Your patients are frustrated by it, but it's the safest way to do it.
Yeah, absolutely helps keep us safe. And that is such an incredibly exciting sort of development, and I wish sort of you and the team much luck with getting that approval. I certainly hope, if the FDA is watching and listening, that that they say yes. Obviously, there are lots of different sort of things that they need to assess to make sure that they feel, hey, this is something safe to do. But given that the medicine's been used, already approved for different uses, it strikes me that hopefully it'll something that'll
from your lips to God's, to the FDA's ears.
Yes. Exactly.
And I think it's important that the people listening understand why things take so long. So I probably get an email every day, at least, from someone who says, can I have liposuction? Can I isolate some stem cell from there? And can I have it injected in my heart or joints? And I always say, well, you can do all those things. It's very legal to have liposuction. It's very legal to do arthroscopy, but we don't know if that's safe and effective. So, but I'm going to another country. I'm going to Thailand, Brazil. I don't name a country. Yeah. And I always think, okay, those people, I believe those clinics are taking advantage of people who want to look younger, want a longer life for their mom or dad. But there's a reason why we do randomized controlled trials. And that's not what patients want to hear. It's not what I want to hear, but it's not perfect, but it's the only way we can do things safely.
So stem cells are often sort of, often talked about as the future of medicine, and yet it's a concept that's mysterious to a lot of people. Can you give us a brief overview of what stem cells are and why they matter?
So this field has emerged very rapidly. So let's think the egg and the sperm come together. You have one cell. From that one cell, you have over 200 types of cells in every tissue developed. So it's a cell that can self-renew. It can give rise to a daughter cell that's just like that one, as well as another cell that's becoming something else. So if you just think one cell to the whole body, that's a spectacular example of what they're capable of. Because and in each of the tissues, in the heart or in the skin or in the liver, there are resident-specific stem cells. So if I say, I back out of a driveway in your house, I'm going to drive to Chicago, there's a lot of ways I can get there. But when I pull into the driveway in Chicago, I'm committed. So you go from becoming any type of cell that would be totipotent, and then there are cells that have become bone, as an example. And those are skeletal stem cells, but they're not going to become nerve. They're not going to become eye. They're not going to become hair, as an example. So it's a cell that can self-renew, make more of itself, and become something else. Now, how many of the something else are totipotent, egg and sperm, pluripotent, nearly everything, and then lineage specific? Oh, you have stem cells in your liver for all the cells in the liver, but they're not going to become bone. So they're capable of a lot, from everything to less than everything, but they're why we renew, for example, right? You have many more cells than you're born with throughout your life. So there's a role for them in normal homeostasis. Normal life requires self-renewal and rejuvenation of tissue. So that's an example of what they are.
Yeah. And what makes stem cells so unique and so important to clinical medicine?
Well, they offer unlimited hope and a blueprint. So if we understand, pick an organ. Give me an example of an organ. Yeah. Skin. So it's the largest organ in the body. It's the most available organ in the body, unlike the liver, for example. No more important or less important, but it's so readily available. So skin develops in a certain way when it's developing. The ability to use stem cells to recreate that offers our ability to reform that or regenerate that in such a way that you would want that. Most of the people listening don't realize that a lot of the dust in your home, if you don't have a pet, is your skin. So every 21 days, this is a spectacular example. Every 21 days, you have an area of stem cells that migrate up and become, let's call it, less and less viable, until they're the outer layer of the skin, which is actually more of a dead layer that sloughs off every 3 weeks. So it's not like we're molting like a snake, but there's an example. Patients don't even realize their skin is being replenished all the time. That's an example of how stem cells are used. And it's different for different organs. Some, like the brain, don't do that. But the skin is an example where it does do that.
Absolutely. That's great. So now that we understand sort of the foundations of what stem cells are, can you tell us about applications of using stem cells today in plastic surgery and aesthetics?
So the way they're used today is not how they're going to be used in the future. So I would envision a future 5 years from now, 10 years from now, where your patients have an incision made wherever it's easiest for you, right? I mean, I always ask patients, why do you think we put a breast implant through the armpit? Or why are we doing surgery through keyholes? It's not easier, but you don't have the scar, right? So be able to make an incision anywhere you want. You'd be able to do anything you wanted and have total regeneration. So instead of injecting things in that give some contour, you could say, look, I'm going to inject some skeletal stem cells, but I only want them to become cartilage in the nose, and you're not going to have to worry about it. It's going to be shaped it's yours. They're your stem cells. So the ability to induce tissue wherever you want it and whenever you want it in a controlled fashion. So one of the things that people worry about, if you got embryonic stem cells, now this is a little different, so it's not yours, okay? So if I had an embryonic stem cell that maybe doesn't have non-self identity, and your audience should know your cells are your cells. There's nothing more personal than your cells. Your cells in my body, I'm going to reject that, and conversely, the same for you. But let's say you have embryonic cells, and I put those under the skin because I want to have a more prominent cheekbones. I'm making that up. Yeah. Those cells are so unorganized. Some of them could become hair, some of them can become liver. It's called a teratoma. It's all these tissues. We can't have that. So we have to have cells that are fully differentiated to what we want. And that takes a long time to understand that, because one multipotent cell would give you the potential for having bone in an area you don't want it, or a tooth to form where you don't want it, etc. So you have to have all the correct guidance on those cells, which takes a long time. Remember the controversy 20 years ago. Your audience may remember this. Like, are we going to sell fertilized embryos? What are we doing that for? And that was outrageously controversial, 1998 to about 2008. What are we doing? How are we doing it? Is that possible? But an orthopedic surgeon from Japan won the Nobel Prize, Shinya Yamanaka, and Shinya said, your audience sitting at home, they could put a Q-tip in their mouth and swirl it around and end up with 500 cells from their oral mucosa. And they're wondering, but I don't want oral mucosa. I want to regenerate something. Think of something else. Okay, Dr. Yamanaka said, I'm going to test a number of factors, brute force, and was able to think of 4 transcription factors, master genes, applied to those mucosal cells that made them like embryonic, but they were already yours. So you don't have to be within 500 miles of an embryo. That's why we don't hear about the controversy anymore. We can take somatic cells, your cells, and reprogram them. So you back them up, but now you have to show they can only become what you want and not something else. So that's still in the body. That's still making sure they're a pure population of only cartilage cells or only skin cells or only hair cells, right? And we're not quite there yet because we can't have liver forming where we want skin. And we can, most people wouldn't want it.
Now, there's probably a lot of listeners who, have heard about stem cell treatments, today, and particularly in the aesthetic world, there are terms floating around like stem cell facelifts and stem cell, fat transplantations and so on and so forth. What do you think is the real sort of current status of those types of treatments today? Are they safe? Are they proven? Are they effective? Are they things that you would recommend, in today's world? Or do you think it's all, hype more than anything else?
So I want to make sure your listeners know that I'm a board-certified plastic surgeon trapped in a stem cell biologist's body. So I'm not here to be critical of any colleague or any surgeon in the world. My role is to make sure that things are done with randomized controlled trials. So if I said platelet-rich plasma, how many times is that injected in the joints or whatever, right? So I always start with that as an example. I don't know if it works, but platelets aren't even cells. They don't have nuclei. So when you start with that, you realize where I'm going. They may work, but they may not work by integrating into, I have tenacell, but whatever the patient has, I have carpal tunnel, whatever it is. Okay, that's fine, except they may not last long, and that's perfectly fine, Dr. Fan, as long as they deliver a payload that modifies some behavior. What patients think is, I have to have a cell incorporate and rejuvenate. Not really, as long as it's modifying inflammation, and I don't know whether that's true. Is it on lots of billboards? Yes. So the medical tourism is particularly problematic in the aesthetic area because people want to believe, right? I mean, liposuction is wonderful. Almost 1 million people have it. But to say, okay, I'm going to suck out my fat, I'm going to isolate cells in the blood vessels around fat, not the fat cells themselves, and those have the ability to become several different tissues, and I can inject them into my knee. I'm making it always up. People are always complaining about joint pain. And I can do this. I can go to a course. You're board certified in plastic and reconstructive surgery. But you could take a course in Florida on the weekend to learn lipoaspiration, I assume, and you can learn how to use ultrasound to inject it in the knee. That doesn't mean you should be doing it because, cartilage, as you know, and your patients may not know, has no blood supply. So if you tear your cartilage, you take it out. So I just caution everyone, if it's a randomized controlled trial done by a board-certified expert and stands behind it, that's fine, right? But a facelift is a complicated operation that experts like you perform daily. It's real surgery, right? These are real operations. Things can work out very well, which is expected, but sometimes patients have, a problem under anesthesia. It has nothing to do with the procedure. So facelifts are a real operation and done to tighten skin and soft tissue. Do I really think you could put a cream on and get the result you get with a facelift? No, I'm sorry, I don't. We're not there yet. Could we be there someday? Yes, but right now we're not there for a lot of the indications aesthetically.
So I know you're involved with some groundbreaking research using a different type of dental stem cells, your collaboration, your work with companies like Stemodontics. Can you tell us a little bit about that work?
So that's an excellent example. The ideal source for stem cells would be from you, by you, for you, your own stem cells. You're not going to reject someone else's. So it turns out anytime you're discarding tissue as medical waste that has a stem cell population, I'm always, stop. Let's look at that. So it turns out about 10 million wisdom teeth, third molars, as you and I would call them, are removed every year and discarded. And the options are, do you want to take them home in a jar? Do you want us to throw them away? Whatever. There's a third option now because the pulp, the soft tissue in the center of the tooth, has stem cells. Now, for your audience, you and I know what neural crest is. There's a certain type of stem cell when you're developing that gives rise to everything from the neck up, called cranial neural crest. Those stem cells in teeth are highly likely to have those properties, and they're yours. And they're yours when you're young and healthy. So I love things like that because why throw them out? Because you don't know what's going to happen to your son or daughter, God willing, but you'll be ready. They're frozen and they can be coached into anything in this tissue, but these tissues are almost everything you need, right, going forward. And frankly, we could probably coach them into become anything. So as the field moves forward, they're banked and ready. You're already asleep. You don't have to have a second procedure. So I see very little downside to not banking your stem cells rather than throwing them out. And Stemodontics is this very clever approach where you don't throw them out and they're yours forever. So that's an example. For example, just think of anything that's discarded in operation. Well, if it had stem cells in it, you'd be less likely to discard it. But very few things, 10 million of which are thrown out each year. So that's a really new example of how businesses are being created so you bank your stem cells at a young age, which is great.
That's very exciting. And I know it reminds me of, the old days, gosh, when I started practicing a long time ago, it was becoming a little bit popular to take some of the adipocytes of the liposuction to do the same thing. And it sounds like this is something that's even better, that the sort of the source of the cells, typically the age of the cells, as well as, what kind of cells and what they can do. It sounds like it's even more powerful. Would that be correct to say?
Absolutely. And they're at a young, healthy age. Less pollution, if you will. Less things have happened to them. And it just makes sense to me. There's no reason to throw them away if you can keep them. And that's a new option. Of course, that wasn't available for me when I had my wisdom teeth out. But let's talk for a minute about what happens if you transplant cells into different parts of the body. So I think the audience should know that your immune system is for you. That we talk about personal medicine, right? Personalized medicine. So if I were to put an implant in a patient, something on their cheek or something on their brow or something in their something in their lips, the body identifies that as foreign, and it has a foreign body response. Breast implant. Let's talk about a breast implant. Usually major indications would be breast reconstruction after a mastectomy or breast augmentation. Those are two big categories. I think you'd agree. Those are not that patient's tissue. So the body has a reaction to that, a little like a coating of scar over it called a capsule. So I think it's important that, and as we're aging, there are millions and millions of implants, some of which are aesthetic, some of which are not. I think if we could manage foreign body response, we could use a lot more of them. So that's one of the things my laboratory has recently worked on. That's a chronic form of scarring. Your body says, "Oh, not you, not me. I'm gonna try to isolate this." That's a problem when it deforms the implant. It's also a problem if it's an EKG electrode or a pacemaker, right? So I think we're now on the threshold of being able to minimize foreign body response by coatings we've put on. And I think that's going to revolutionize how plastic surgeons use implants. If you can minimize the scar walling off as foreign, that would be great for your patients. And that's coming sooner rather than later.
Obviously, that's tremendously exciting. So much of human medicine, health, and disease, the two extremes, the balance of sort of too much or too little, right? Like foreign body response, often too much of that creates problems at the same time. Too little of a response, and then sometimes there may be issues with healing or wound healing, for example, not enough response, delayed healing or an absence of healing. Too much of a response, we end up with a hypertrophic or overgrowth or hypertrophic or keloid scar, too much scarring. Same thing with cancer and, et cetera. How do you think, what do you see as far as how, as a scientist and as a surgeon, as a doctor, how are we going to be able to balance the two sides of the response of trying to get?
This is a great question, Dr. Fan, and I will use a spectacularly active system in your body, your immune system, right? Too much immune system that you can attack your own tissue, graft versus host, connective tissue diseases, many forms of musculoskeletal problems are examples of your immune system being overactive. It can be overactive because you had COVID or an infection, right? We need to fight infection. We need to protect ourselves, but too much of it is a two-edged sword. So as we learn how to modify our response to anything, especially foreign body, we'll be able to accept a lot more things. For example, the people not listening may not know as we sit here, we're getting closer and closer to having pig organs modified such that they would be tolerant in humans. Wouldn't that be great? I mean, everyone's like, what? They have these sugars on each cell that have prevented that, but now we're close. And that's going to revolutionize the way we look at transplantation. But too much and too little typify the immune system, right? You have an implant in, the body doesn't like it. It should be obvious, but you're thinking it's ruining my reconstruction, it's ruining my aesthetic result because the immune system is trying to put a wall around it and deforming it. We'll be able to modify that going forward, but you're right. Too much or too little defines wound healing, ulcers on a diabetic foot, or a hypertrophic scar keloid. But I think we can modify the immune system such that it attacks the cancer, but doesn't attack the rest of the tissue. So you're right. We're just beginning to understand what we need. You remember if you're on liver transplant surgery, UCSF is one of the leading places in the world. So steroid suppression, so they'll accept that liver, is a nightmare for the wound. So, we want to be smart about it, and that's coming. So the immune system and connective tissue problems are very difficult to treat, rheumatoid arthritis, other things like that. But I think we're getting better and better at how to modify the immune system specifically, so it's not a gross on or off.
And these obviously are significant issues that people have been working on for literally decades. And, it sounds like you've indicated that, for example, you've been working on sort of scarless wound repair for more than 30 years. And that sounds like you feel like we're very close in many of these key arenas. What do you think have been the principal, advances that have allowed, that have gotten us much closer? And maybe another way of asking this is, there are some people who maybe have been following the field for a long time, and they've also said, well, gosh, I've heard about this stuff for 20, 30 years, and it's still, I still don't see it in real people. Why should I believe or be excited and feel like, hey, it really can happen in the next 5 days?
Look, I get it. The boy or girl who cried wolf, right? As I said, President Kennedy and President Nixon had a war on cancer. We still have cancer, right? Gene therapy was going to cure everything. But you know what's happened now? We have remarkable breakthroughs with CRISPR, the molecular scissors, Nobel Prize from Berkeley, that were able to cure patients with complex disease, sickle cell, things like that, never thought to be possible, right? Those trials are positive. These people are having the defective gene cut out and replaced and be cured. I couldn't have sat here and said that 5 years ago. So I get it. Oh, don't talk about this breakthrough because I'm never going to see it. Well, here's an example where you see it. And, having applied to the FDA for our first in-human trial, within a year, I want to be able to open that trial. Now, maybe not. Maybe it's 18 months, but it's happening. Getting pig organs into humans, it's happening, right? We are doing face transplants. We are doing hand transplants. The immune system is still fighting us, but that's all possible. So I always ask the patient, turn around and look behind you. Look at how far we've come. I know for your mother, yourself, your father, each individual, it's always gut-wrenching because it didn't happen in time for. But look where we're at. I mean, CRISPR, the molecular scissors, have approved drugs to treat genetic diseases. Okay, that wouldn't have been possible. But remember, for your audience, hundreds of thousands of people are cured with stem cell transplants called bone marrow transplantation.
Yeah.
You have a single cell called a hematopoietic stem cell, blood-forming stem cell. All the red and white blood cells come from a single cell. You give someone bone marrow that's a match, and it replaces them. That's every day patients are cured. Just remember that. There are examples of stem cells, and everyone's like, I know, but my dad's paralyzed. I want him to walk. Okay, that's a tough nut, but we're getting better. What if I said with an exoskeleton, you can be up and walking? Everyone's like, what? You know what I'm talking about. They don't realize how things have moved forward. And for your audience, I get it. It's never fast enough. But it's the ability for the other disciplines. Like at Stanford University, I have a co-appointment in bioengineering department, co-appointment in material sciences. So bringing electrical, chemical, mechanical forces to bear on the body is a good thing when we harness it. So it wasn't just the white coat in a room. Discoveries are made by teams working together and then massive analysis of data. That's all possible now. I'm not saying AI is here to change everything, but it's made my job easier to look for key genes that I wouldn't see manually. So I think it has been frustratingly long. I share that. But I can tell you that we're close on so many fronts. And your patients, 5 years from now, my guess is you're going to be doing operations very differently because of what you can do now.
Yeah, and that's great. I couldn't actually agree more. Like at one level, the pace can sometimes seem like it's really slow, but there is so much, investigation and work that needs to be done to establish sort of the safety and the effectiveness and to develop new treatments. And yet at the same time, if we look back at all of our lives, even going back 20 years, for example, we're in a completely different world, and there's so many avenues where, not only in health and medicine, but in technology, so many areas of our lives have been transformed, and that's exactly what's happening with sort of regenerative medicine.
Well, and I think if your plastic surgeons don't have their own organ system, we joke skin and its contents. Well, skin and its contents could be with the neurosurgeon or the heart surgeon. We're trying to solve problems all over the body. We see the impact of the diseases differently than that organ-specific person, right? So I think plastic surgeons are problem solvers, and no one's more frustrated than a plastic surgeon when they can get a reconstruction, but it doesn't look like normal tissue, right? That's what you want. You want to establish normal. Yes, the hole's filled, but it's not filled with like. We always want like to replace like. But think of where we were 20 years ago. If I said we were doing face transplants, you just said, what? If I'm going to do a hand transplant, you just said, what? So believe me, it's coming. And the FDA is not the three worst letters in the world. It's actually the safest, most rigorous body in the world. And it's also very frustrating. But you know what? I wouldn't have it any other way. But we are going to get scar-free healing into the market in the next few years. It's already been 37. It's not going to be a lot more. That would be unacceptable. And I know patients are frustrated. I'm frustrated.
Yeah, that's so tremendously exciting. And when that happens, that will be such a big advance for all of us. Now, I wanted to ask you, what are you most excited about the future of stem cells and regenerative medicine? Aside from all the things that we've talked about already.
So I think being able to move tissue around and having it survive, most of your patients don't realize if I suck out fat and put it somewhere else, it's really without a blood supply. And it's unpredictable how much it'll survive. Do I routinely have to put twice as much in? That's frustrating for the surgeon. When you do a facelift, if you didn't know how it was going to come out, that would be a nightmare. Well, with things like transferring fat to plump something out, we don't know if it stays. One thing we know, if the patient gains 50 pounds, that will proportionally gain weight. So we have to do a better job of being able to modify the transplanted tissue in the case of fat transplant to be just what we want, and not more and not less. Because right now it's unknown, and you have, in the last 10 years, you have a feel for it, but your first 5 patients, you didn't know, the lip or the cheek. I mean, these are, and patients are unhappy and you're unhappy. Now you know what that is in your hands, but I want to make it very predictable on how much tissue survives, because most patients don't realize if I take fat out of the body, it's actually not, it's not going to survive. It doesn't have a blood supply. And when it goes back in, it has to recruit a blood supply before it dies. So it's a race, but maybe we're putting things in there that maximize the probability of it'll be predictable. So I think you'd be able to contour anything without a foreign body, and it would be predictable. What surgeons want is predictable result. That's what patients want too. And I don't think we're quite there yet. We're better, but I think there's some things we could do to help you with tissue transplantation that gives you a predictable result. So if you could make an incision anywhere you wanted, and you could modify contour any way you wanted without having problems of blindness and injections around the eyes, etc., you'd be happy. The patient would be happy. But I think the real thing is, we're not Benjamin Button, right? We're not getting younger during this podcast, right? One could argue as a male, my prostate is enlarged during this, think about what aging is on the margin. So how do we tap into looking younger? But that's a complex thing because we're exposed to sun, right? People aren't helping themselves by having actinic damage. Now, I'm married to a dermatologist. So the biggest oxymoron in our house is a healthy suntan, right? That's like, so we have to do a better job of preventing damage on the margin every day. And then what can we do with stem cells for skin to rejuvenate the skin? But it's more than that because it's sub-Q tissue. You know what aging is in the facial skeleton. It's not just the skin. So I think we can do that, but we have to really understand how to modify the skin in terms of keeping it from aging. How do we keep the sub-Q fat? And what happens to the skeleton? If we knew those things, we could have a patient with the same contour that they want. And we're not there yet, but we're not far off. I think facelifts are going to be around for a long time. I think they're going to be different. And I think tissue transplantation is going to be really much more of a part of it. The facelift is the base, but then for that patient, but the surgeon just wants to know, is it predictable? We're not there yet, but I think think of how you do a facelift today versus your first year in practice. You've incorporated things that work and don't work. And I'd like everyone to have your experiential ability at the beginning because of what we're doing, and we're not there yet.
And so if we want to get really practical for people who are listening, like, if we look at the state of the world in 2024, do you think there is a place today for stem cells in the areas of aesthetics, regenerative medicine, and even people who, people who want to look younger, people who want to feel younger and maybe slow down or turn back the clock. Do you think there's a place for stem cells today?
Not exactly, right? They're just not quite there because I want to look younger. I want to feel younger. I think if people in general, they won't like this answer. If you don't smoke and you keep your weight down, those are two gigantic things, and try to stay out of the sun. But, patients get stiffer as a function of time. The musculoskeletal things, not pleasant. They're not dying, but they're not happy. So I think if people maintained their weight, minimized their sun exposure, and stretched every day, that would go a long way to the feeling that you're slowing down. What you're saying is the Holy Grail, reversing. And that's going to be a bit of a long slog, but I think there are ways we can do skin tightening without surgery. We're not there yet. Right? When Fraxel came out and you had the crust or CO2 laser, it does a great job of removing the dead outer layers, but it doesn't give you the tightening you want. It'd be great if it did. I mean, patients would love it, but it didn't work. So it's going to be a combination of new technology like that, how to keep tissue surviving, and then minimizing the damage each day.
Super exciting. It's been a wonderful discussion. Thank you so much for coming and having this conversation, and I look forward to more.
Absolutely. Thank you for having me.
To our listeners, thank you for joining us on this journey into the world of stem cells. Remember, staying informed and consulting with qualified professionals is key to making the best choices for your health and beauty. Be sure to subscribe to the Fan Method podcast for more expert insights and tips on looking and feeling your best. If you enjoyed this episode, please leave us a review and share it with your friends. For more information and resources, visit our website, www.77plasticsurgery.com. Follow us on social media for the latest updates, and join us next time as we continue to explore the art and science of beauty and wellness. Stay fantastic.